All right, so our second speaker is Dr. Khaled Almerri from Kuwait, consultant intervention cardiology from the Chest Hospital, and the talk is about the management of acute unprotected left main occlusion in ST elevation myocardial infarction.
Assalamu alaikum. Good morning, everybody. So I'm going to talk about this topic. Thank you for giving me this topic, which is really not really common, and there is no much data on it. So why don't I start with some cases? Because acute occlusion of the left main and ST elevation MI, it's not one type or not one presentation usually. So this is one patient that we had. He had a subtotally occluded left main with STEMI 1 flow, and you can see the ECG here. He has right bundle branch block, AVR ST elevation. He presented with pulmonary edema, LV dysfunction, and he received an intra-aortic balloon pump. This is first patient with somebody with subtotally occluded left main, but some flow in the coronaries. The other patient is this guy who was having a acute total occlusion of the left main with no flow into it, and he presented with ST elevation and again AVR ST elevation. And the LV function, as expected, is really poor here. And this guy needed, despite we opened the left main, he had to have he received an intra-aortic balloon pump, and that was not enough due to arrhythmias and persistent shock. Then you can see an ECMO was inserted. The third example here is somebody with ST elevation MI anteriorly with some haziness in the left main and STEMI 2 flow. And this guy did not receive any circulatory support. He had some moderate LV dysfunction, and he was not in shock. You can see all of those patients had acute left main occlusion or subtotal occlusion with ST elevation MI, but the presentation is different. So acute MI due to unprotected left main is not really common and depend on the registry you're reading. It ranges from just less than 1 to 4%. But the incidence of a real total occlusion of the left main may be underestimated because patient, most probably, they will not make it to the hospital. So we don't really know what's really the incidence of this entity. So if we compare patient with left main disease, when they present with ST elevation compared to non-ST elevation, clearly those patients will present with more cardiac arrest, more cardiogenic shock, and they are sicker patient, and most of them, they die in the hospital. And their ECG presentation. So if we compare to the left main ST elevation MI patients, if we compare their ECGs to the non-left main, usually they have wider QRS complexes, longer QT intervals, and most probably they will be having ST elevation in the AVR. And more frequently, they get right bundle branch block. And there are two groups. There's one group they present with the right bundle branch block and left axis deviation, and almost all of those, they will have an ST elevation in the AVR. And the other group is like our second patient, they had ST elevation anteriorly, and 2/3 of them, they will have an AVR ST elevation. So AVR ST elevation is really very common in patients with left main disease. Right bundle branch block carries a high predictor of death compared to non-right bundle branch block in this group. Their presentation usually depend on the degree of stenosis and the flow in the coronaries. So usually they present with heart failure, bundle branch block, low ejection fraction. Usually they have higher mortality. And also they have higher chance of being on mechanical circulatory support. So if we compare the left main patient to non-left main patient and ST elevation MI who are going for primary PCI, left main patient, as we have seen earlier in the previous slides, they have more LV dysfunction, more cardiogenic shock, and more MACE and hospital MACE. And all other clinical predictors are higher in those patients, including ventilation and multi-organ failure. So predictor of mortality in those patients. One, whether they are in shock or not. Two, the degree of stenosis of the left main. Three is the flow into the coronary arteries, degree of the LV function, and coronary dominance. If we look to the patient who present with shock due to left main ST elevation, they are having extremely high risk compared to patients who do not present with shock. And if we look to this slide here, we find shocked patient with TIMI 0 to 1, they are the worst. And non-shock with good flow, like our third patient, they do reasonably well compared to the other groups. And if you look carefully here, that mortality difference happens early on when they're on their presentation. So it means if you pull them out of that acute event, the long-term follow-up, they do really well if you look to the 12 months follow-up. And there are two groups of left mains, occlusive and non-occlusive. The third patient I show, if you can remember, was non-occlusive. The other first two were occlusive. So if somebody present with more than 70% less than one TIMI 1 flow, they do really worse compared to somebody with more better flow and more than 70% stenosis. And again here, if we compare the left main to non-left main, cardiogenic shock is the highest predictor of mortality. And if you look to the left main patient themselves, if they have occluded left main or compromised flow and shock, they're even having even worse outcome. And this is very interesting here. Not only that, if patient having collaterals, if they have right dominance or if it is occluded. If you look here, if patient has no coronary collaterals and he is having occluded left main, almost everybody here dies. So collaterals are important and are protective in this group of patients. The other thing is TIMI 3 flow into the coronary arteries post-procedure. So if you stent the patient or balloon the left main, what matters is not only the TIMI flow before you start, is the TIMI flow when you end. So if you look here, if you end up by non-TIMI 3 flow, the mortality of the patient extremely high. Coronary dominance. So in the right side of the screen is those are patient all comers, whether it is totally occluded left main or somebody with some TIMI flow in the left mains, and we find left dominant system carries higher mortality. In the left side of the screen, those are patients who had complete occlusion of the left main, and usually they die. And like a left dominant system in this group of patient is incompatible with life. Then, so this group of patient, which is totally occluded, it is really uncommon, but when they present, they will present with cardiogenic shock, and their presentation can be dramatic and catastrophic. So you have to work fast and quick. And if we look to this group of patients, we find the incidence of that is ranging from 0.8 to 2.2. Usually they present with cardiogenic shock, and usually they will have an intra-aortic balloon pump during their management, and despite that, more than 2/3 of the patient, they die. So if we look to the role of intra-aortic balloon pump and ST elevation MI, it is not recommended routinely, as we know from the guidelines, but there is one paper on a group of patients who they have a severe LV dysfunction with high score. So this is a high-risk group patient. In this paper, patient who had intra-aortic balloon pump, they benefited from having an intra-aortic balloon pump. So if we look to our patients who are left main occlusion patients who usually present with LV dysfunction and having extremely high risk, if we look to the graph here, is if the patient present with cardiogenic shock, left main patient present with cardiogenic shock, an intra-aortic balloon pump showed benefit in mortality if you use it. What about stenting or POBAs? Should we do POBA or stent? Patient who had stents, they did better than patient who had POBA. What is the role of CABG? Basically, your role here is to maintain the flow as soon as possible. So people with left main occlusion or less than TIMI-3 flow, you have to maintain the flow. So you have to proceed with PTCA. A patient in cardiogenic shock or life-threatening arrhythmias, again, PCI is the revascularization option of choice, or the patient is non-surgical. So basically, acute MI due to left main occlusion is uncommon, but when it happens, patients will come with severe LV dysfunction, and they will have rapid hemodynamic deterioration and catastrophic clinical presentation. The incidence of cardiogenic shock here is high, and the usage of mechanical circulatory support is common and should be encouraged, and priority for restoring the flow into the left main and hemodynamically support the patient. Thank you.
Khaled. All right. So thank you for this great talk. I think we have a question from the audience over there.
Okay, thank you very much. Dr. Almerri, you started with intra-aortic balloon pump and you end up with intra-aortic balloon pump recommendation in a cardiogenic shock with left main unprotected. Do you believe that we have benefit from intra-aortic balloon pump in presence of the umbrella and ECMO and other things? Because the 3 cases you have presented, all of them, you have utilized intra-aortic balloon pump.
Well, it depends. It depends on the situation. Sometimes you can get away with intra-aortic balloon pump, and I don't think this group of patients is represented in the trials that like intra-aortic balloon pump shock trial. So those patients are not presented in any randomized trial, so we have no evidence for that. But it depends on the degree of the hemodynamic deterioration, so you can start with an intra-aortic balloon pump, and depend on your comfort zone with any of those devices. So if you're comfortable with an Impella or ECMO, you can choose whatever depend on the patient's clinical status. But mostly, or most of the centers in the world, they only have an intra-aortic balloon pump. They don't have other circulatory support devices.
Okay, thank you. We have one more question from the audience.
Dr. Khaled, thank you very much. Nice presentation. Now, practical point. I think about this rare occasion, which is unprotected left main occlusion. The way I see it is that if the patient is beyond at the stage of shock, I think the best course of action is to do hemodynamic support. Yes. Don't play with the coronaries because they are already occluded. So I think the device suggested, which I found it very useful, is a combination of ECMO to start with, and later on to reduce the LVEDP probably by intra-aortic balloon pump. I believe in this situation that Impella is a bad choice because you really go inside a sick ventricle which is infarcting, so the chances of complication is very high. So I think if he's in shock, just support him, then do what you have to do with the coronaries. If he is in stage 1 or A or B of shock, I think then you are racing with the shock and you have to go and open the vessel. So is that a fair practical comment on your presentation?
Yeah, actually, I agree with you. Those patients will have lots of arrhythmias, and Impella will not work in those patients. And if the patient is already in stage D and E, and he goes into biochemical shock, I think Impella will not really help much. You will have to put him on some circulatory support like ECMO until you do your PCI. So if you pull him out of that event, his chance of survival is higher. I totally agree with you.
I see.
Well, I don't agree, actually. I'm sorry, I don't agree with the last statement at all, because I think, we all agree that opening the artery and restoring reperfusion is the key in recovering these patients. So it is implementary and it's very important to do hemodynamic support, but whatever you have balloon pump, you have Impella, you have ECMO, it doesn't matter, whatever you have, that's important, but at the same time, you should try your best to open the artery as soon as possible and restore flow. And in my experience, I have done that many times, and CPR is going on, and I'm trying to push between the CPRs, my wire and balloon, and the moment the artery is open and the flow is restored, everything is quiet, everything is back in control. So I don't think we should focus on hemodynamic stability, and then when we have it, we play with the coronary, as my colleague said. We have to try our best to open the artery from the beginning.
Okay,
Thank
great.
you. We have one more question from Dr. Imad, and maybe a comment,
Actually, no
basically.
time, but just a small, short comment. I think it is one of the most challenging situations. And as you said, most of these patients will die before arrival in the hospital, so it's underestimated as well. I think surgery in this situation is much more beneficial than PCI, because PCI gives you the possibility to restore flow much earlier than surgery. So in this situation, I think what can be done only by angioplasty and not by surgery.
Yeah, we have seen that patient who made it to the cath lab, 1/3 of them, they will die in the cath lab. So this is really very high mortality. And almost 45% of those patients will die in the first 24 hours. Those are the patients who makes it to the cath lab. So this is really high-risk group patients. So you need a strong mechanical circular support, and you need to open it immediately.
And of course, it depends on time between the manifestation and arrival in the cath lab as well.
Yeah, definitely.
Okay, thank you.
Excellent. Thank you very much.